2024 UCSF School of Dentistry Global Oral Health Symposium. Thank you so much for taking time out of your day to join us, whatever time of day it may be where you are. My name is Ben Chaffee. I'm the director of our school's program in Global Oral Health and professor of oral epidemiology and dental public health at UCSF. This event started all the way back in 2011, following the leadership of the late Professor John Greenspan. John envisioned the symposium as a way to pull together norm-challenging ideas from around the world. And today, thanks to some advances in digital technology, we can truly make this a global event, available for live viewing to anyone with an internet connection. We have an outstanding lineup of speakers today. They'll share very different perspectives on a single topic. If you look below to the chat feature, you'll see a link to this year's program. It includes brief biographies of our speakers and some overviews of their talks. You'll also see that this year's theme is advancing oral health among Indigenous communities. And I should note that when we speak of Indigenous communities, that's placing a broad umbrella over a heterogeneous collection of peoples, each with unique experiences, cultures, and histories. However, remaining in those broad terms for a moment, we can describe the disproportionate burden of poor oral health among Indigenous communities, a disease burden that is unjust, based on its roots in colonization and an ongoing history of racism and discrimination. Our speakers will approach this multifaceted problem from the perspectives of clinical care, research, and professional education, drawing on experiences in 3 different countries: the United States, Canada, and Australia. We hope you enjoy their presentations, and we also invite you to join the conversation by sharing your comments and questions via the Q&A function. We'll have time for a few questions at the end of each talk, and we'll have a somewhat longer moderated conversation at the end. And I'm happy to say that those sessions will be moderated by Dr. Kristen Kearns, Associate Professor of Oral Epidemiology and Dental Public Health here at UCSF, and a member of the Lancet Commission on Global Oral Health. Right now, technology willing, I'll share with you a short recorded message from the Dean of the UCSF School of Dentistry, Dr. Michael Reddy.
Greetings and welcome to our school's 13th annual Global Oral Health Symposium. I'm Mike Reddy, and I have the privilege of serving as the Dean of the UCSF School of Dentistry. Thank you all for joining us today, and a special thank you to our speakers from Australia, who, if I'm doing the time zone math correctly, I believe you're joining us from early in the morning tomorrow. Thank you. This symposium has a record of drawing world-renowned speakers in supporting vital research projects in public health, epidemiology, and basic sciences in the realm of global oral health. Research is central to our mission and is a big part of why the work we do at UCSF has worldwide impact. This year's theme is Advancing Oral Health Among Indigenous Communities. This is a critically important topic, and I'm thrilled that it's receiving the focus it deserves. We are grateful to have our talented presenters today to share their wisdom about how to improve oral health in Indigenous communities. So to all our speakers, thank you for being here. I also want to thank Dr. Ben Chaffee for leading our global oral health initiatives at UCSF and for organizing this symposium. Ben has once again gathered leaders from all corners of the world to share their work and inspire us. Let today's speakers encourage, energize, and propel you in your own efforts toward achieving positive changes in global oral health. Your work has never been more important. Again, thank you, Ben, and thank you all for attending.
And thank you, Dr. Reddy. And in the interest of keeping this online symposium aligned with online attention spans, we'll move quickly to our speakers. And as distinguished as they are, and as honored as we are to have them, we'll keep their introductions brief. So first, our speaker is Dr. Herenia Lawrence, Associate Professor of Dental Public Health and Director of the Indigenous Oral Health Research Group in the Faculty of Dentistry at the University of Toronto. Dr. Lawrence, the floor is yours.
Sorry, I'm just getting my slide up. Okay, Hello, everyone. Thank you very much, Dr. Shaffi, for this opportunity to participate in this year's UCSF Global Oral Health Symposium and to present some of the methodologies we use and some of the study findings from the Nishtani Wipta in Ojibwe, Nistani Pta in Cree, and my first tip study. My presentation is titled From Learning Circles to Caries Arrest, Baby Teeth, Silverdamine Fluoride, and Indigenous communities in Northern Canada. On behalf of our group, I would like to acknowledge the Remayetush Awani people, who are the traditional custodians of the land that UCSF sits upon. We pay our respects to their elders, past, present, and future, who call this place their home. There are numerous health inequities between Indigenous peoples, First Nations, Inuit, and Métis, and non-Indigenous peoples in Canada. And those inequities are not unique. We have inequalities and inequities in oral health as well. Available national surveys report a considerable difference in the probability of Indigenous children and adolescents experience dental caries and having sealants placed in comparison with non-Indigenous children and adolescents in the general Canadian population. Likewise, the rates of early childhood caries, ECC, differ substantially between Indigenous and non-Indigenous children, particularly for First Nations children living on reserves. The customary use of general anesthesia for treating decaying baby teeth has become the norm rather than the exception in Canada's north. During COVID, the high rates of hospitalization, including the administration of general anesthesia to treat cavities with stainless steel crowns and extract the decayed primary teeth of First Nations children, increased even more, with hundreds of children waitlisted for urgent care in some areas. Percent in 5 years, with an average of 8 out of the 20 baby teeth affected by dental caries. Who were CC, only 1 in 3 received their most recent care from a dental professional stationed in the community. So geographical barriers, notably the remoteness of the community, remains a significant barrier to timely access to care, and one that is very difficult and expensive to overcome. Prevention and health to solving the considerable dental disease rates among Indigenous children. Health Canada currently supports 2 ECC living on reserve and those living in the territory of Nunavut, the Children's Oral Health Initiative and the Nunavut Children's Oral Health Project. Both programs target children and pregnant women and provide fluoride vanish and sealant applications, temporary fillings, and one-on-one or group oral health education sessions. In 2018, an expert panel convened and published a clinical practice guideline on non-restorative treatments for carious lesions in children and adults. The panel recommended silverdamine fluoride, or SDF for short, to arrest advanced cavitated carious lesions on any coronal surface of primary teeth. Our Nishtani-Wiptan study evaluated the use of SDF for managing early childhood caries in Indigenous children. The study adopted a community-based participatory research CBPR approach, and as such, community consultation meetings were held prior to applying for funding to plan the details of the design and implementation of the intervention, as well as creating a knowledge mobilization strategy. Once funding was obtained, ethics approval was sought. CBPR requires outside researchers to function within a cross-cultural setting, and concerns related to ethics often arise. Various frameworks for ethical academic research involving Indigenous communities or peoples have consequently emerged. Most notably, the First Nations principles of ownership, Control, Access, and Possession, more commonly known as OCAP, which was developed and trademarked by the First Nations Information Governance Center to be used as a framework to negotiate research relationships where First Nations rights to own data, to own their own data, are protected. Echoing the First Nations principles of OCAP, other Indigenous groups have their own set of guidelines, principles, and values that inform research in their respective communities. Some of these are listed on the slide. So once we obtained the necessary institutional and community level approvals for the study, we sought engagement with groups of interest to participate in the study. For example, in the Nishnani Wiptan My First Steve study, we hired and trained a community-based researcher, or CBR, in each of the participating communities, who was then responsible for organizing the learning circles, also known as stalking or sharing circles, with parents of young children to provide information about the silver diamine fluoride study. Learning circles are built around equality and power sharing among participants. And for many First Nations, the circle represents the nature of life on Earth, and they have traditional ways of running the circles. This is typically how we start our projects, with information sessions nested in learning circles that are conducted in each community, usually in public health centers, nursing stations, or in housing facilities. To keep the audience engaged during these learning circles, we show videos and tell stories that are related to the research topic or intervention. And participants are invited to share their personal experiences as they relate to dental care in their communities. We also distribute dental care products and play games and award prizes during breaks. We provide monetary incentives for participants, say $50 per participant in cash or gift cards for groceries, and pay transportation costs to and from the meeting place when possible. We also seek input from our research partners regarding the appropriate types of incentives. For example, in the Baby Teeth Talk study with pregnant Indigenous women, the study provided packages of diapers as incentives and in thanks for their participation. The Nishnani Wiptan study had two phases, with the first phase exploring parent or caregiver perceptions and decision makers' perceptions of SDF as a minimally invasive treatment option for ECC through Indigenous learning circles. Using a mixed method sequential exploratory design, phase 1 results informed phase 2, which evaluated the effect of SDF combined with fluoride vanished in a community-based trial. Between phases 1 and 2, the COVID pandemic occurred. So COVID disrupted dental services delivery in remote First Nations communities, but served as an opportunity for program providers to implement minimally invasive dental practices, such as using silver diamine fluoride, which does not generate aerosols. So what is SDF? What is silver diamine fluoride? It is a liquid composed of silver and fluoride ions, which possess antimicrobial properties and are used in the remineralization of tooth enamel and dentine for preventing and arresting cavities. In February 2017, Health Canada approved 38% sodium silver diamine fluoride under the brand name Advantage Arrest. The advantages of SDF greatly outweigh its disadvantages. SDF can slow and even stop tooth decay. Its benefits include low cost and ease of application. It is not an invasive treatment, it's pain-free, and no significant side effects have been reported. The major side effect is cosmetic, with permanent black staining on the affected tooth surface. It does not stain healthy teeth, although there have been reports of a metallic or bitter taste on application, which we overcome by sealing the cavity with fluoride varnish after SDF is applied. Now on to the results. The learning circles with parents and other child primary caregivers were conducted in 5 participating communities in 2018 and 2019. The circles were also conducted separately with 31 decision makers, such as the health director and program managers, healthcare providers, and some members of the chief and council in each of the 5 study sites. All the learning circles started with a presentation and a video of how ECC is treated in the operating room, followed by a video about the SDF application, its advantages, and its major side effect, which is the staining of the affected tooth area. At the end of the learning circles, parents were asked to fill out a questionnaire with 13 statements. Some of the main concerns discussed by both groups were about resistance towards the dark staining and the need for an education component to explain the benefits of SDF. Overall, caregivers and decision makers recognize the benefits of SDF, especially as it is a non-aerosol treatment. Engagement and knowledge sharing with the community is key to the acceptance of SDF use among caregivers and local decision makers. I am able to read one of the quotes. I have time to read one of the quotes. I will read, "Grandmothers have a lot to say about their grandchildren. So tackling and normalizing storytelling about SDF is where we have the greatest chance of engagement." Okay, how do I put this back up? Okay. On the next slide are just some photos taken during and after the learning circles. Analysis of the parents' response from the 13-item questionnaire revealed that most parents accepted and welcomed the SDF treatment for their children, particularly when the alternative treatment involved extractions under general anesthesia or when the child experienced dental pain. However, parents residing in reserves that were near urban centers were less likely than those in remote communities to accept the staining on their child's front teeth, but they had no problem with the back teeth. Bullying and stigma were the reasons given by parents living near urban centers for not choosing SDF for the front teeth. On the other hand, parents living in remote communities reported that the black spots, the SDF treatment, right, look much the same as their child's untreated cavities. And they were happy that their children got to keep their teeth without pain and not have them surgically removed under general anesthesia. Phase 2 of the study was a community-based trial of SDF for ECC management. Unfortunately, the start of the trial coincided with the onset of COVID, and because of travel restrictions and community lockdowns, we could not implement the trial as originally planned, and our plan for semi-annual applications had to be revamped. This slide shows the study methodology. Children aged 2 to 5 with at least one cavity and no toothache who received the application of SDF with fluoride varnish in 2019-20 were followed up in 2020-21. The goal was to see if the cavities had stopped or were still progressing. The study adopted the First Nations principles of OCAP mentioned earlier, and prior ethics approvals were obtained from the University of Toronto REB, also from the Community Research Ethics Review Committees and Chiefs and Councils. The dental examiners and community-based researchers were trained prior to the start of data collection in July 2019, and recruitment started that summer in the communities listed on the slide. With the help of these partners, 180 preschool-age children and their parents or other primary caregivers participated. The table shows the number of child participants recruited from each community. Out of those 180 children, 111 or 62% were followed up. More could have been followed up if it had not been for the pandemic. SDF was applied on 820 cavitated lesions, and caries arrest was observed in 82.6% anterior and 68.4% posterior surfaces, and the difference is statistically highly significant. By 6 months, 99.6% of cavities were arrested. By 12 months, 64.6% was still arrested. And by 20 months, 61.1% showed signs of arrest. These results were also statistically highly significant. You can see in the photo of the child on the top right, marked with a question mark, a lot of plaque deposits on the buccal surfaces of the anterior maxillary teeth. But even in this condition, signs of arrest were observed in some of these teeth. So the findings indicate that First Nations living in remote northern communities demonstrated the highest acceptance rates of SDF as compared with those residing on reserves near major urban centers in the South. Caregiver education is vital to SDF's introduction in Indigenous communities, and so is community buy-in that comes through consultation, knowledge sharing, and ongoing support. From the community-based trial conducted during COVID, we learned that a single SDF application can arrest caries progression in primary teeth for most lesions and children and for even longer follow-up periods. However, given the very high rates of caries in this population, a 4 to 6 months interval between SDF applications is recommended for sustained benefits until the baby teeth fall out naturally. These findings suggest SDF can be used to effectively manage tooth decay without the need for hospitalization for dental treatment under general anesthesia. We have not finished the study yet, as we are at the knowledge dissemination phase. The study adopted various knowledge mobilization strategies, much like an interactive knowledge loop, as the project progresses throughout the stages. This includes, but is not limited to, the distribution of briefing notes to chiefs and councils, health directors, and program managers, oral presentations to community partners and other stakeholders, engagement with local media via radio interviews, and use of social media that can reach those who participated in the research and the community at large, as well as infographics with the study results. As part of knowledge mobilization for the NISHTAM study, we organized with our partners in Thunder Bay, Ontario, a workshop on minimally invasive dental practices with Dr. Jeanette McLean. The target audience was dental professionals in Northern Ontario who work closely with First Nations communities in their region. To date, our team also made knowledge dissemination visits to other study communities for the purpose of gaining our community partners' feedback on the interpretation of the results. We would then incorporate their feedback into the study publications, as well as sharing authorship of those publications with the community partners. Over the past few years, the focus of our group's research has moved to one that is more strengths-based, and I have two examples of these approaches. One such project carried out in Norway House Cree Nation, Manitoba, was led by Janelle Brown-Walkus, who is a member of the Heiltsuk, Squamish, and Kwasala First Nations in British Columbia. Janelle completed her Master's of Science degree in Dental Public Health with us, and as part of her thesis, she co-developed with child caregivers and decision makers in Norway House a scale to measure the quality of preventive oral health services for First Nations communities, the QPOSIC. Janelle used the method of concept mapping, which is a process for representing ideas in pictures or maps, a research tool that is relevant and useful for community-based researchers working in Indigenous communities because it helps to engage community members in the participatory analysis of learning circle data. It involves the generation of statements through brainstorming, as you can see on the yellow stickers in the slide, then structuring the statements into teams, representation of this statement as a concept map through cluster analysis, followed by interpreting and utilizing the maps. It is very adaptable to Indigenous contexts as it allows for high levels of engagement and thus strengthens ownership of the research project among community members. With community participation being the central component of the CBPR framework, new avenues of research our group is pursuing consist of co-constructing oral health interventions with Indigenous partners, interventions that are grounded in Indigenous people's strengths and successes. that are countering years of Eurocentric research methodologies. This approach involves incorporating traditional and cultural knowledge and practices that have worked for millennia into oral health interventions for young Indigenous children in Canada, including swaddling, breastfeeding, country food, traditional medicine, and storytelling, albeit via digital storytelling. So finally, here are 5 things to remember. First, the social and commercial determinants of health in Indigenous communities are powerful barriers to effective oral health programming. Preventive oral health interventions alone will not bring about substantial improvements in disease rates unless communities are involved and engaged. Community-based participatory research, CBPR, facilitates collaborative, equitable partnerships from design to dissemination, building on community strengths and assets, promoting joint learning, skill sharing, capacity building, and the co-creation of knowledge among all partners. CBPR uses Indigenous and decolonized research methodologies, frameworks, and principles. Thus, findings generated via CBPR are more culturally relevant and spring from the community itself rather than from the researchers. And finally, the increased validity of the results with greater cultural and social relevance to the population and increased likelihood of lasting positive change. So this brings me to the end of my presentation. On this slide, almost everyone who played a pivotal role in our project's success is acknowledged. And I would also like to acknowledge our partners with their logos depicted on this final slide and the financial support from the Canadian Institutes of Health Research. Thank you very much.
Well, thank you. I'll turn it to Dr. Kearns to see if we have maybe time for one question.
Terrific. Yes, we do have a couple of questions, but maybe just the one to address now. There was a request for speakers to briefly indicate if they are Indigenous or not, and give us a little on your background.
Oh, okay. I am Brazilian. I'm not Indigenous. I am a professor of dental public health, but I have lived experience working with Indigenous populations for the past 25 years.
Thank you. And I think we can reserve the other question perhaps for the end.
Okay. Thank you.
And with that, why don't we bring in our next presenter? Dr. Maximillion Jensen is a board member of the Society of American Indian Dentists, and he's a practicing dentist in Alaska, the United States. Dr. Jensen is also a graduate of our school here, and therefore he is very welcome to come back and visit anytime he'd like. Dr. Jensen, I'll turn it over to you.
Hello? Hi, can you all hear me?
Yeah, we can hear you. Go for it.
Okay, perfect. Is it me or the PowerPoint? My apologies. And surprisingly, I'm not too tech savvy. Let's see. Okay, perfect. So I'm Maximillion Jensen. As Ben said, that I am a graduate of the UCSF School of Dentistry, class of 2015, and I am a practicing dentist. In fact, I'm at this moment an intermittent dentist. So I actually travel across the region of Alaska. I started my journey way north. Currently, I'm actually in a village right now, and I just finished about 2 weeks of dental care. I work for one of the largest tribal health organizations in Alaska, South Central Foundation, and as Ben said, I am a member of the Society of American Indian Dentists, which was founded in 1990 by the first American Indian dentist, Dr. George Blue Spruce, an incredible man, along with 5 other Native dentists, with the idea to encourage more Native people to go into the career, such as myself. So I actually found this organization when I was in dental school, and it really helped me a lot to gain confidence that there's more Native people get into this career to help our communities. Just as a brief plug-in, this summer we are having our annual conference from June 6th to 29th, so if you have interest, that'd be great. Moving on, I kind of want to talk about my story in terms of weaving my clinical experience and some of the Indian Health Service surveillance survey data that we have in regards to Native populations in terms of the oral health disparities. I say top of the world because as soon as I graduated from UCSF School of Dentistry, I had a service obligation with the Indian Health Service to provide dentistry. Originally, I wanted to go back to my own reservation, which is Navajo in the Southwest region around New Mexico and Arizona. But I chose something different. I felt like it was something I needed to do, and I chose Barrow, Alaska, which is about 300 miles above the Arctic Circle. So it is extremely isolated and remote. And even as a Native person myself, there was a sense of cultural shock because I was accustomed to some ways of being Native in terms of being familiar with reservations and rural life, but not to the magnitude that I experienced up in the slope. I learned that there really isn't any reservations in Alaska. In fact, in the entire state, there's only one reservation, when in the lower 48, there's over 300 reservations that are federal lands. And that got me really interested and fascinated to stay here even longer in Alaska, working with more tribal corporations and villages. And that's something I like to talk about in brevity real quick, not to get into the thick of the demographics, but this infographic right here kind of gives an idea that where American Indian, Alaska Native people can kind of be found. There's a lot of historical reasons why there's mostly towards the west into Alaska region of colonization, a lot of historical trauma, treaties, assimilation, Indian removal, and boarding schools. Those definitely play a role and are definitely lingering parts of historical trauma that I've seen as a clinician for people even wanting to come into a dental clinic. With that aside, 570 plus tribes, I just kind of want to touch upon that because when people find out I am Native, they want to know which tribe I belong to. And I think commonly most people think about either Navajo because it's large. People say Eskimo, but it's really Inupiaq up here in Alaska, and Cherokee. But in fact, in the US population, there's about over 570 different tribes. So these all function as sovereign nations, so they get to self-govern in the way that they feel is fit for their community. So that's a really staggering number. That's 570 different customs and cultures and language and practices. And sometimes that can be difficult to collaborate, but something they all do share in common that was discussed previously from our speaker is the decay rate. It's extremely high compared to the counterparts of white children. And that's something I knew beforehand in my background because I grew up what you would say an urban Indian. So I wasn't in a reservation, but my uncle still lives there, my grandma. So I still have family that are in reservation systems where they don't have access to water or electricity at times. But times are changing, so there's been some improvements. But children at that age do have a high consumption of carcinogenic foods and experience a really high decay rate. So with that being said, when I was in UCSF, I took a lot of pediatric classes because I knew I was going to be seeing a lot of children from a clinical standpoint. And with that, it still didn't prepare me for what I had to see in terms of the sheer volume and magnitude of clinical work. In this slide, I became known as the native dentist because I was often found to be the first time seeing a dental provider that's native. Despite not being from the slope, there was the sense of understanding that we're part of the same people collectively in the US. But from there, I learned that in the bottom right, there's a little picture of myself and two of my colleagues. Us three from 2015 to 2017 were the only dentists that was clinical serving the entire Arctic region. And there's 5 remote villages. So on the top left in this photo is an airplane. We had to actually bring our dental gear to go out there to provide the service. And oftentimes we'd have a lot of decay. As Dr. Lawrence had shown in her presentation, an extremely high ECC rate. Unfortunately, you had to weigh the benefit and risk, and we had to still do immobilization with a papoose to remove infected teeth from really young toddlers. And in the top right, a little sad face is a lot of tooth removal too, even from adolescents. So there's a professional shortage of dental providers, and including those who are native themselves. And the cost to get in a plane is extremely high. These villages that exist can range between 20 to 300 people. And the cost for an airfare can be 500, 600. And if there's not a lot of job opportunities, you're kind of in a catch-22. And they do have a high carcinogenic diet. And when we talk about nutrition and preventative services, as you can see, there's an avocado that's almost $5. This was taken in 2017, so I'm sure it's probably $5 or over. So food insecurity is definitely a thing that I've seen in terms of getting adequate, nutritious foods that are non-cariogenic. In this slide, it kind of highlights what I've seen in the last 3 months in my travels going to remote villages throughout Alaska, from the Pribilof Islands to even where I'm at now. As you can see, the only fruit or vegetable I see is an onion and potato right in the middle. So everything is extremely cariogenic, and it's because the cost of transportation for fresh fruits and vegetables is definitely a thing. In the middle slide, this is one of the villages I have a heartfelt thing to it because I went there a lot, and I just would go there, but weather was such a thing. Weather permitting, I could go over there if the weather was permitting. So even if you ordered fresh fruits and vegetables by airplane, it may come spoiled because it's just waiting at the airport. So sometimes it's at first, when I first started my career, it was easy to think that, like, whoa, that's what we need to change. We need to stop with the chips, the Lay's, the Gatorade. But at the same time, these are the longest lasting food shelf stable foods that some of the community can get. But not all is lost. This from the surveillance survey from the Indian Health Service does show some good things on here, although the disparity is quite high for adolescents, and that's something I've seen too. In the last 2 decades, we see that there is a reduction. And when I became onboarded in every tribal health organization, there's always like an old timer, someone who I look to their wisdom and then guidance as a practitioner. It's definitely changed. Things definitely improving in terms of what we're seeing of disparity. There's less tooth extractions. There's less referrals for having to remove teeth or even do a lot of GA referrals. So there's pockets that still exist, but it is slowly improving, and the gap is narrowing. Again, that's a lot of children, and this also extends to the childhood to adulthood of American Indian and Alaska Native people. Again, untreated, and it carries experience is still quite high compared to the overall U.S. population, but and that continues on. And some of the reasons, again, as you can really see that I'm trying to really highlight, is the access to care issues from a geographical standpoint and even from a professional shortage is alarming. That's definitely one of the contributors, but also in this slide, I want to highlight the infrastructure. This village that I go to is in their clinic in the gym area. So there is no formal dental setting. We have to wheel out this chair. We have to break everything down. Again, we have to bring our equipment. And if the weather allows, or if there's space in the plane, sometimes we have to bring half our gear, so we lose a day. When we go out to these villages, I may go for a week, I may go for 2 or 3. But if I'm going for a week and I'm delayed by a day or 2, that's significant. That's impactful. That means that my trip is not going to be as a success in my mind in terms of ameliorating the disease rate. I still use SDF, by the way. So like that's something that's nice that Dr. Lawrence emphasized, because I have to be really savvy and manageable with the time I have here. Again, this is a different village, and I'm actually in a gym. So we had to bring a compressor, and there's a lot of logistical planning in these situations in terms of where space is available. And if the equipment's functioning, in this case, one of these village trips I went into, the water actually, the water pipes froze. So our trip, needless to say, had to be rescheduled because the temperatures in Alaska in this region, at least in the interior, can drop down to about -60, -50. And, if your anesthetic freezes, it's kind of useless. And in this slide, I kind of want to talk and pivot a little more. This is a lot of information that I would love to share, but I kind of want to get to near the end where I talk about what I notice is missing teeth. Children are definitely something that I love seeing and I have a huge passion for, but as I practice longer and contribute to removing teeth from adults, I started to see a lot of elders come in from time to time, and they're missing not one, but nearly all, or enough teeth where they need to go to dentures. And in that case, I kind of was lucky where I met the Port Graham Village, and this village council had actually really invested heavily into wanting more dental services expanded beyond children. And this is what I realized, that it's possible to bring more services depending on infrastructure to native villages and populations to expand beyond children. With children, I think we are doing a fantastic job and we continue making strides. SDF is such a fascinating thing to have in our pocket to use to prevent more infections. But as I work with more geriatric patients and encounter more malnourishment, we decided to use a scanner and a 3D printer to fabricate crowns and dentures to this remote community. So it was cool. It's the first that I've ever been exposed to in terms of a native village really kind of coming together as a small community and pulling the money to try to purchase these equipment. And this is kind of some of the highlight that we did, that when we were in the village, there's a lot of decay rate for children, but because we started going there so frequently and started using a lot of glass ionomer and using SDF and kind of doing the smart technique, we started to get some stability where it allowed more time for me and other providers to start possibly doing more dentures or possibly a crown, because the community as a whole, they know that and accept the idea that I'm going to focus on children. It wasn't until I started saying that I'm going to see some adults late in the evening that I started to get bombarded with a lot of adults who want dentures and desire to eat again. And that's something that would be an interesting research topic that I like to see, is getting a better accurate depiction of the edentialism that is facing the older generation. Because as we can see, decay rate has always been high now, but I can only imagine what it was when it was first introduced, the high sugary diets. And as soon as we started offering dentures, it opened its own can of worms in terms of what we're able to do and the need. With that being said, these are some of the things that we see with American Indian oral health disparities being contributors. Definitely historical trauma. Every village I go to, whether I've been there before or it's my first time, there's always a form of historical trauma that this community and population faces. There's a distrust sometimes to some of the systems of healthcare given to them. And I think as being a Native provider and being Navajo and sharing my story and having some sense of relatability, I do get a little leeway to and more trust. And I think even culturally too, that allows me to have that relatability. But culturally, I think there's also still a barrier, because even though me being Native as well, there was some competency that I had to do myself going from a different region and part of the world to a new community. Economically, there are some very wealthy villages and there's some that are not doing as too well. And that kind of creates sometimes these political rifts of how many dental trips should be allocated to one versus the other. And then that's compounded with geographic issues in terms of weather, available flights, and professional shortages and research. These are ongoing things, and I think that's something that is worthwhile. I think we should still continue more research into it. I'm just a clinician, and I just use the research that y'all use. And as soon as I heard about SDF, I started implementing my practice as soon as possible. And in terms of technology, I think that's something I look forward to the future. Some of the public health policies in terms of doing surveillance. When I was a student and first starting out, I didn't really think about how important it is, but as I've gotten more mature in my clinical practice, it's vital, it's imperative to sway opinions of tribal leaders to invest in some of these things. So I think all the researchers talking today and those who are studying to help with that. And I just want to thank everyone's time for taking the time to listen to my story and sharing it.
That was fantastic. Thank you so much for sharing that perspective. I think we have time to get in a question before we move to the next speaker.
Right, so you do a couple of questions. The first one is, why do you think adolescent oral health has improved?
Oh, well, I think since we started the surveillance program within the health service, there's always been a focus on children. And before SDF, there was definitely a lot of push to do a lot of children examination and sealants. And that's something I didn't get to mention. I forgot, my apologies. But according to the Indian Health Service survey, Native children in the U.S. get twice the average of sealant placement. So that probably had some contributing features to it, as well as more visits to the dentist and providing some education to them.
Great, thank you. And the last couple, maybe we can come back to in the end, or perhaps you can answer them in the Q&A section as well. Thank you.
Yeah, thank you so much. And thanks for everyone who's offering questions in the Q&A. We will do our best to get to them either in writing as we go or at the end of the symposium. Our next speaker is Dr. Cathryn Forsyth. She's an honorary senior lecturer at the University of Sydney, and she'll share her perspectives on developing a curriculum framework to integrate Indigenous cultural safety into dental professional education. Dr. Forsyth, thank you so much.
I think my PowerPoint's up. Can you see my PowerPoint?
Yes, we can.
Yep. Okay, I've just got to arrange the other part of my screen, and I think we're ready to go. Hello, I'm from Sydney, Australia, and I'm so pleased to be with everyone here today. I'm a non-Indigenous academic researcher and clinician, and over the last 15 or plus years, I have learnt much about Indigenous history in Australia, especially about the historical significance, and we've had some of that shared with us today. And I suppose I see part of my role is making my current role redundant, as I've built relationships with many wonderful Indigenous people in Australia. We're able to see a positive shift in more Indigenous clinicians and hopefully one day researchers as well. That's still yet to come. But actually, Lisa's probably going to be able to share more about that from another part of Australia. But I see that there's a lot of positive things happening, and I'm going to be sharing more from a cultural perspective, my learnings and how we're trying to have a positive impact in Australia for future. So let's see how we go. So I'm sorry, I've just got to move my field. So I'd like to acknowledge Australian Indigenous peoples and Indigenous peoples worldwide for their continuing connection to culture, language and country, along with elders past and present here today, and ancestors that walk with Indigenous people every day. I'd like to recognise the traditional owners of the land on which this research was conducted, the land of the Gadigal peoples, the Darug peoples, and the Wurundjeri peoples. I just think that there's so much that we can do as we work together, non-Indigenous, Indigenous peoples, to further and advance Indigenous oral health worldwide. So I'm going to be looking a little bit at cultural safety, cultural competence. I use these interchangeably in this presentation. And I find this cultural safety or cultural continuum model quite helpful in understanding what cultural safety looks like. Initially, we may hold false knowledge and understanding about a particular culture, which can be quite destructive. However, over time, as we increase in our understanding of particular cultures, we're able to adapt management of patient care to achieve the best possible outcomes. And this cultural iceberg, which our National Centre of Cultural Competence at the University of Sydney developed, is useful in explaining the various levels of cultural representation. And items displayed on the surface layer are often what we all feel safe to reveal about ourselves, such as food and fashion, art and holiday destinations. Cultural safety is being conscious that there are many cultural layers in each of us and the patients within our care. Cultural safety is also being able to understand that these cultural layers affect the way all people perceive the world, which impacts on health beliefs and health outcomes. So why Indigenous culture? Why not include all cultures? In Australia, despite several Closing the Gap campaigns over many years, Indigenous people still carry the greatest burden of disease in both general and oral health. And cultural safety is fundamental to healthcare and quality of life in addressing these health disparities. Traditional dental curricula has a strong focus on restorative and surgical care, and we still need good clinicians. But our team is calling for an increase in focus to incorporate more social aspects of health in programs in Australia and worldwide. I'm pleased that the Australian Dental Council, which accredits all courses in Australia, they now require evidence of Indigenous cultural curricula in all programs in Australia, and that's a really positive move forward. So to provide context for our research, this diagram includes the various philosophical frameworks employed. Dentistry, being established on the Western biomedical model, defines good health as the absence of disease, concentrating on the individual physical and biological components of the human body. And with increasing advances in technology, the biomedical model of care is helpful in treating many common conditions effectively, improving quality of life and extending life expectancy. As this research was conducted in university settings, it was fitting to incorporate higher education theories and practice to assist in understanding how students learn, to develop effective teaching practices, and to design valid assessments. The systematic review we conducted in 2016 particularly focuses on higher education cultural competence, content and strategies. So dental and oral health students ought to participate in disease prevention, health promotion and delivery of clinical care throughout their programs. And the social determinants of health attempts to address the broader influences on health, such as social connectedness, social economic position, and various environmental factors, recognising the relationship between the social determinants of health and health status. And I'm sure many here today realise that development of healthy public policy involves intersectoral collaboration, promoting actions to reduce social inequalities and empowers individuals and communities to make positive change to their health. So this cultural research was viewed ultimately through an Indigenous methodologies lens. Indigenous methodologies identifies power imbalances that have existed since colonisation and examines dominant and oppressive policy. And throughout the last 15 years or so, I've had many times where my own personal views have been challenged as I've reflected on my own misperceptions, biases and stereotypes. Several fundamental principles were adopted while conducting this research. Firstly, we challenged power relationships built on Western ideologies, strengthening and supporting the fight it is to alleviate social conditions that result in poor quality of life for Indigenous peoples. We privileged the Indigenous voice to depict various experiences of Indigenous peoples and ensured that non-Indigenous populations were aware of the concerns and the ambitions of Indigenous peoples. We included Indigenous community within our reference group to ensure equal distribution of power and responsibility. We recognised colonisation as a social determinant of health. And our team was well informed of colonial influences and the historical dispossession of Indigenous land, tradition and cultures. And I'm not sure if I've actually stated this, but our research team was a combination of Indigenous and non-Indigenous peoples, as well as our reference group being that as well. So the cultural interface, and this is my representation, although Martin Nakata has written about this since 2004, this is my experiences in research and clinical care. So the cultural interface is where Indigenous and non-Indigenous peoples engage with each other and learn from one another. As we focus on Indigenous ways of knowing, being and doing, there's a focus on relationships and engagement with community, building trust and respect and advocating for social justice. And from my experiences with non-Indigenous healthcare specialists, researchers, clinicians, there's often this focus on a business model, ensuring the key performance indicators are increasing and that reconciliation plans, action plans are actually developed. And they're not a bad thing in themselves, but often it's a plan that's enacted and then put on a shelf and not delivered. So that's something that we've seen as a challenge. And then there's this idea of developing social responsibility. And it's good that there is some accountability, but I'm not sure if it touches the heart of where people are. So some Indigenous researchers would favour Indigenous research only being conducted by Indigenous peoples. But Professor Martin Nakata, who's an Indigenous academic here in Australia, felt that this was counterproductive and that non-Indigenous people should be involved in research in collaboration with Indigenous researchers, as long as Indigenous methodologies are employed. And during development of this research, we collaborated with our reference group and multiple academics as we reflected on our research findings to aid in the development of an Indigenous cultural competence model and later a framework. So following completion of 4 scientific studies, this Indigenous curriculum model was developed. 3 areas were identified as being critical to achieving cultural competence of dentistry and oral health students upon graduation. And from the left of your screen in the red, we have supportive institutional governance. In the orange, faculty implementation. And in the yellow, individual participation. Implementation of effective cultural safety curricula requires governance at a national level, university-wide level, as well as school and faculty levels. So building authentic relationships, which takes time, and that's something that is also a barrier. You're not going to improve anything unless you actually get to know people, right? So building authentic relationships with Indigenous peoples and having adequate educational resources is crucial to curricular development. So careful integration of Indigenous cultural safety curricula using a combination of didactic or online strategies, as well as some sort of cultural immersion and reflection upon this. Those 3 key factors were essential to increasing knowledge, skills and understanding for students. And it's anticipated that throughout university degrees in Australia that there is a positive shift in this understanding of Indigenous culture to the point where there's a minimum standard of cultural competence achieved upon graduation. So to improve the cultural safety of academics, professional staff and students, the Australian Council of Dental Schools commissioned and funded this project. I was very fortunate to be involved with this. Professor Julie Sartor and Joanne Bolton from the Melbourne University, we worked together in collaboration to develop this comprehensive curricular document incorporating 6 key domains. And those domains being reflect, respect, communication, safety, quality and advocacy. And these key domains are integrated into the curriculum from early on in dental and oral health programs, right through to when students are transitioning to clinical practice and then to graduation. So this document includes multiple strategies and activities and resources to assist academics to achieving positive cultural safety outcomes. This is publicly available. I commend this to you to have a look and would appreciate any feedback on it as well. So given that I say 10 plus years, it's been actually more than 15 years working with Indigenous colleagues, how far have we come? And I'm pleased that the number of Indigenous students in dental schools is moving towards parity with the 3.8% Indigenous population in Australia. However, ongoing support is required to ensure Indigenous students and clinicians continue to grow in number and feel culturally safe. We've also fortunately got this Indigenous cultural training being incorporated into dental schools. And one of the big challenges is ensuring that we have adequately trained academics and healthcare workers to deliver relevant and engaging cultural safety curricula. We've also got the Indigenous Dental Association of Australia, which started at a similar time to our Indian one that we just heard. And so the Indigenous Dental of Australia has grown from a handful of dental clinicians to more than 30 registered dental clinicians. And I'm really hoping that some of those will be leading the way in academia, in clinical care, and in research. So I've just got a little photo of them here, and I commend you to look at their website to see what sort of vision and mission and activities that they incorporate in their working lives. A great bunch of people that I've really enjoyed working with. Now, this is a very busy slide. I don't expect you to be able to read it, but this project involved many people. And if we're looking at such complex issues, such as improving Indigenous health in Australia and worldwide, we need to have a broad team. So I would like to thank the many Indigenous and non-Indigenous academics, social scientists, clinicians, and community members that have been involved in this research. It's necessary if we're going to tackle these complex issues. So thank you very much for this time.
Well, thank you so much. Why don't we see if we have a question before moving on to our keynote?
We do have one question. So it's kind of a comment leading to a question, not exhaustive, but a few significant challenges in the education space. Indigenous students are very few, as the bar for entry is very high, and Indigenous academic staff are also non-existent. School has a very part-time Indigenous staff member, and even enticing this colleague to the school was difficult. Who should be teaching this curriculum? Some non-Indigenous staff expressed reluctance teaching the recommended curriculum, lacking confidence.
Excellent questions, and that's really encapsulated the challenges that we face. I think over time we're seeing a change in this space as we work together with our Indigenous colleagues, and build trust and relationships. I'm really thankful that from Sydney Uni, we've had more than 15 graduates over the last 15 years. And it's maintaining that momentum and then having pathways. So I suppose getting back to that first question of entry into dental and oral health courses to start with, we've had some really good success with Indigenous peoples that are working as dental assistants, and then looking at doing university preparation programs to then articulate into something like a Bachelor of Oral Health, and then dentistry if they choose to do so. And that has worked well, but once again requires ongoing work in this space. And there's so many competing issues with universities. It sort of comes and goes, ebb and flow as far as its priorities.
Yeah.
Well, thank you. And we can get back to this at the end of our session today. But now our final talk is our keynote presentation, and we're truly honored to hear from Dr. Lisa Jamieson. She's professor and founding director of the Indigenous Oral Health Unit at the University of Adelaide, and a world expert in this space. And really, we're fortunate to have her. The quality of her work and its impact, second to none. So please, Dr. Jamieson.
Thank you so much for the kind words, Ben, and I apologise for being late. It is 8:30 in the morning in Adelaide in Australia, and it's pretty chaotic in our household on any given morning, and today was a shocker. So I'm very grateful to be here. Let me see if I can share my screen. Here we go, share. And then I want to go. So Ben, for some reason, oh, here we are. Share. And then if I go like this, I'm trying to get, can everyone see this okay?
Yeah, I see a picture of your colleagues.
Wonderful. Yes, okay. So thank you so much. I will commence my talk now, and I will just take a note of the time so that I don't go over. Okay, thank you so much. So I'm going to be talking today about advancing the oral health of Indigenous communities with a specific focus on Australia. Wee bit of background for you. I am a New Zealander. You can probably tell that from my accent. I graduated with a dental degree from the University of Otago in 1994. And I always knew that I wanted to use my dental degree to do volunteer work. So I spent 4 years working in Africa, in South America, in the Pacific Islands, spent a bit of time in Europe as well, and sort of was thinking I was going to be saving the world by, administering dental care, but pretty soon came to the realization that pulling out teeth is not really going to help in the long term. So I turned my eye to public health, and I think that I was about to go to Mongolia to do another stint of volunteer work, and I ended up back in Dunedin because I had amoebic dysentery, and I was fortunate enough to meet Murray Thompson, and he just loved his job, and I thought, oh, I want to enjoy my job as much as he enjoys his job, and so I started doing a Masters of Community Dentistry with Murray, and then went on to do a PhD, and have never looked back since then. So really, the program of work I'm going to be presenting to you today has built on a passion of mine growing up in sort of a poor region of New Zealand, and recognising that my life is quite privileged compared to a lot of my contemporaries. In Australia, it is very respectful to always give an acknowledgement of country. I've been in Australia for 20 years now, and when I first arrived, nobody did this. It was you just kind of did your presentation and you just went on with it. But I think that there's been a big movement. I think coming from New Zealand, where there's a very strong social justice pattern of the Maori, the Indigenous New Zealanders of New Zealand, I was a little surprised that Australia wasn't acknowledging its Indigenous cultures quite as strongly. But I tell you what, it's come a long way since then. So I will give my acknowledgement of country. to move the people. So I acknowledge the Kaurna people as the traditional custodians of the land on which I work and live. I recognise Kaurna people's continuing connection to their land, water and community. I pay my respect to elders past, present and emerging, and express my gratitude for the sharing of this land today. My sorrow for the costs of that sharing, which is substantial, and I hope that we can move to a place of equity, justice and partnership in the future. And similar to what Cathryn was saying, a lot of the work that we have done in the past 20 years has been hand in hand in partnership with the various Indigenous groups, mainly in Australia, but also in New Zealand, also in Canada. We've done some great work with Herenia. In the US, we've done some work, and in South America as well. And also actually in Netherlands, Finland has an Indigenous population as well. The presentation today, you know what happens in academia, the higher up you get, the more you end up being a manager rather than a researcher. And so I have relied heavily on my postdocs to help me produce the data for this presentation. I don't know if you can see my little arrow here, but the top left is Joanne Hedges. Joanne is a Indigenous elder. She is she's been part of our unit for nearly 13 years now. She has been instrumental in the success of all of our projects. Many of you may have met her at various RDR conferences. She's a wonderful person and I'm very grateful to have her as a colleague. Moving along, we've got Gustavo. He is a postdoc from Brazil. He's done a lot of work in Indigenous populations in Brazil and is leading one of our randomized controlled trials now. Brianna is from Canada originally. She has been doing a lot of work around the nutrition space and has a strong strength in qualitative research. Bottom left now we have Sneha. Sneha's from India. She's got an oral pathology background, but she's been leading our oral human papillomavirus and oral pharyngeal cancer project, which involves over 1,000 South Australian Indigenous people. And we've got funding now for the next 5 years, I believe, for that project, so that's good. And then Sonia is also from India. She recently completed her PhD. She won the Hatton Award. She's a real shaker and mover. She does a lot of work around the oral microbiome space, so the oral microbiome transplantation space, and also measuring the effect on comprehensive culturally safe dental care on the changing oral microbiota. Okay, advance my slides. So a little bit of an overview of what I'm going to be discussing today. I'm going to give you a wee bit of background, and I hope I don't overlap with what Cathryn has already presented. I'm going to give you some snapshots of some of the work that we've been doing over the past 10 years or so, and then moving forward with some concluding comments. And I apologise if this has been said before, but just I'm sure people are aware perhaps now of what the sort of United Nations definition is of being Indigenous. It's really having a historical continuity with land prior to colonisation. And the UN recognises that there are many similarities in the issues that Indigenous peoples face throughout the world, largely as a product of colonisation. Australia's history is quite it's not well, it was one of the worst, I think, because there was never any indication of the land belonging to Indigenous persons. When the first white settlers came, it was declared as terra nullius, so belonging to no one. I'll let you just read those other words yourselves. You may have seen this map before. I present this a lot when I give my presentations. It really just demonstrates the many varied and distinct language groups of Indigenous persons in Australia. So there's over 360 language groups. And I think it's very easy for us as academics to lump Indigenous persons in Australia using the umbrella term Indigenous or Aboriginal Torres Strait Islander, but really there's a lot of distinction between various states and territories and various groups. I think it's probably also important to note that Australia has a population of around 30 million, but they are largely around the east coast of the country, so well, certainly coastal anywhere. So in the middle, it's just a big geographic vastness of mainly desert. It's very arid, it's very, very hot, and it's difficult to access. It's a huge country. To fly from Sydney, which is east coast of the country, across to Perth, which is west coast, is about a 4-hour flight. So it's a large country going from east to west. I'm going to just describe a little bit of the social situations which occur when we are in these really remote locations. So the Northern Territory is where this red dot is placed. And I'm going to just describe a little bit of a town that we have been doing a lot of work in called Alice Springs. So Alice Springs has a large proportion of Aboriginal persons. There is a large movement, often from remoter communities, who come into Alice, and there's just not a lot to do. There's very high unemployment, and I think that the boredom and the clan conflicts which often happen, and there's a lot of drinking of alcohol, there's a lot of drug abuse, there's certainly a lot of violence, has led to the government having to consider it to be under sort of police control. So this vulnerability and this explosive patterns of behaviour, which, you know, this is not uncommon in the Northern Territory, has led to a stereotyping of Aboriginal people in Australia, which on face value, it would appear that there's a lot of crime and it's due to poverty and unemployment and that sort of thing. But historically, there's a lot of triggers which have led to the situation. So I think if we just take a bit of a step back, I mean, all of the literature that we know around chronic diseases demonstrate that there's just much higher prevalence of type 2 diabetes, cardiovascular disease, chronic kidney disease, obesity, overweight, poor mental health, incarceration. Like, no matter what you think of, the outcome is always going to be much worse for Aboriginal Australians. I was listening to a statistic on the radio yesterday, and it was the adult population of Australia was 2.6, adult Aboriginal population of Australia was 2.6%, and yet 30% of those in prison are Aboriginal. So there's a lot of inequities. So we have done a lot of work around all the different oral disease in terms of surveys, but also just trying to do some interventions as well. So there's just a couple of papers talking to that. In Australia, the funding that we get for research is largely through the National Health and Medical Research Council. So it has become more and more difficult to get funding for specific oral health initiatives that are purely oral health. So what we have tended to do now, we've got to play the funding game. So you've got to be strategic in terms of what the government wants to fund. And so often they want to have these multidisciplinary approaches. So that is why we have tended to have intervention approaches, which include a lot of chronic disease outcomes. So I'm going to talk about some of these now. The silver fluoride project, silver diamine fluoride. I just love silver diamine fluoride. I think it's an absolute game changer, especially when we are working in remote communities in Australia, which struggle to have a dentist. If they do have a dentist, they are often culturally unsafe. The Aboriginal participants don't like to come back. They have a lot of fear, but they have a lot of shame around oral health as well. They will often cover their mouths. We had one participant who was a fabulous singer, had been invited to give a sort of recital on the local TV station, but didn't want to because they were so embarrassed about their teeth. So this is what have we got? We've got 1,140 kids enrolled in this, of ages 2 to 18. We've got 11 different sites across Australia, and it's a delayed intervention approach. So we've got those who receive the intervention immediately and those who receive after 12 months. The issue, silver diamine fluoride has been around for a long time, and the issue has often been that it stains the teeth black. But we've got a new application now that you apply the silver diamine fluoride and then you immediately apply potassium iodide, and the potassium iodide absorbs those loose ions which would otherwise cause the black staining. So that has been fabulous. So the image on the left shows a youth who has active decay at the front, has had silver diamine fluoride applied and the potassium iodide, and no staining. So that is very, very exciting. So we also... So this is what I mean about getting the funding. So we were really interested in seeing how silver diamine fluoride, first of all, how it was accepted in the community, and the impact on dental caries. But the funding that we got was really around social and emotional wellbeing, ECWB, and quality of life. So we kind of threw those in as well. And some of the images on the left-hand side just show the different settings in which the staff work. So this is the project that Gustavo leads. And right at this minute, he's up in a remote community in Queensland with a team of 5, I believe. One of them's just got COVID. So yes, more images to come. These are some of the information pamphlets and consent forms that we use. We work very closely with different ethics committees. Each state and territory has their own ethics committee, so we need to tailor all of our resources to suit them. And it's been great. We get a lot of feedback back from participants as well, because I think research has often been a scary place for many Indigenous Australians. So this has been something which has been a mutually beneficial experience for most people involved. Just some more images there. I've got a lot of images in this presentation because I think sometimes the pictures speak more than the words. So you can see diversity in our team. There's a lot of camp dogs where we go. The kids are just adorable. And we have a lot of help from the community health workers too. And these are just some of the partners that we have. So in Australia, we have Aboriginal community controlled health organisations. They are funded directly from the government to provide care for and by Aboriginal people. And Gustavo has got a wonderful way of presenting the data back to community as well, because that is always something that they are very keen to find out once we've made a visit. So the oral human papillomavirus project, this is the one that's run by SNEHA. So these are just the different time points. So time is at baseline and then 12-month follow-up. We've basically taken saliva samples from the very beginning, and we followed up 12, 24, 2 years, what's that one, 4, 5 years, and we're collecting data. I think we're in the sort of pinky purple stage now. We discovered from the baseline findings that the oral HPV genotypes that we were producing, that they were about so with oral pharyngeal cancer, it's HPV 14 and 16, which are the nasty ones. So we didn't have a high prevalence of those. But what we did find, 16, 18, sorry. But what we did find was a really high prevalence of HPV 13, 32, which leads to HEX disease, which is kind of a mottling of the oral mucosa. So the second lot of funding that we received, we wanted to do clinical examinations as well, because we wanted to see if there was the clinical manifestation of the HEX disease, given there was such a high prevalence of the biomarkers for it. So again, these are the different field settings that we have. We do anthropometrics as well. At night, it means that we have to use headlamps and all sorts of things. We do a lot of work in participants' homes because we just cannot get access to a dental clinic, and if we do, the folks don't want to go there anyway. So a lot of the home visits mean that participants are more and more willing to see us. So some of the findings are there. And they're just showing 70% of those with an oral HPV infection had 13 and 32. So that's quite substantial. That's definitely not been published before in the literature. Again, and you're just throwing through. So even when we follow up, we still get those interesting ways she presented that data. So yes, hopefully we're going to be following up this cohort over time. We have found that there's, as you can see on the flowchart on the left, there's a reasonable number of deaths. There's a lot of incarceration. There's a lot of movement interstate and other restrictions as well. So with the saliva samples that we collect, we send them off to a laboratory who have a bespoke way of testing for many of the different HPV types, because a commercial laboratory don't typically measure HPV 13, 32. So we've got quite a lot of work going on with that. And yes, just some more follow-up story. I think that what is a real success story with this, so first of all, it's recruiting over 1,000 participants, and this is again down to Jo. I think she personally met every single one of those 1,000 participants, but we managed to retain close to 80% at 12 months and at 24 months. And this was at the height of the pandemic. I'm just gobsmacked that we managed to do that, because there were so many closures, there were so many communities that weren't accepting other researchers, and a lot of the country basically shut down, like a lot of the rest of the world. And I put this pretty much down to Jo. Again, she just would keep on ringing, she would keep on establishing those relationships, and they wanted to see her, they wanted to see us. And so yes, we were very grateful for this retention rate. Okay, another project which Sneha has been running is the end-stage kidney disease dental project. This was a direct request from some of the remote communities we've been working with who have high rates of chronic kidney disease, which then lead to end stage, so ESKD5, and without a dental, a tick of approval for good oral health, you cannot be waitlisted for a kidney transplantation, which is really the only way to avoid having dialysis. So we were approached to provide a service for all of the end-stage kidney disease Aboriginal people in South Australia, and then to evaluate whether that led to a higher uptake of kidney transplantation. So these are the different sites. These are all sort of remote communities apart from Adelaide. This is the team for this one. Again, there was a bit of overlap because the HPV study was also in a lot of the different sites, and so we were able to cross over for both of those. That was great. A lot of the places we go to are very beautiful, so I hope I'm encouraging you to think about a trip to Australia. There was a lot of consultation with this work. I mean, kidney disease is a hot topic in Australia, but we really wanted to make sure that we brought along the renal team as much as the oral health team and all of the health worker as well. So a lot of work that went into the sort of the exploratory phase and then the intervention phase, which was around really navigating what the dental care pathway is, because far out it is very, very confusing. It moves and changes all the time. So there's no it's very easy to understand why folks just don't want to go in terms of following up with their dental care. So this is one of the workshops that we have, just joining together all the dental, Indigenous and renal stakeholders, and some of the suggestions that came out in terms of getting more and more dental into the renal health space. So we had in total 43 who were eligible for the study. So I think that there were probably more, but what happens with the end-stage kidney disease in the Aboriginal space is that it's a very rapid decline to death. And so we were really hoping to nip it in the bud so that we could provide that dental workup so that there'd be a much higher chance of kidney transplantation. So we did manage to recruit 36 into the study by the end. Some of the sort of demographic characteristics there that you can take a look at. So 50% had visited a dentist since dialysis, 40% weren't aware that poor oral health could impact the kidney transplant. Yes, just a whole bunch of other things there. So Centrelink is basically government welfare. So there's a lot of poverty in our group that we work with here. Diagnosis of kidney disease at 16 years is a very disturbing figure. That's a very, very young age. So we're finding that more and more that chronic diseases are starting at a much younger age with Aboriginal Australians, which leads to sort of much more severe conditions such as cardiovascular disease and kidney disease in their teenage years. This is just an image of all the different consultation groups that we have. So our Indigenous Oral Health Unit has a big sort of meeting every year. So those are the different stakeholders for that. And then there's another group that we work with that's more in the renal space. All right, culturally safe dental care. So again, just working on what Cathryn was presenting about. So we were interested in looking at how changes in the oral microbiome might be connected to chronic disease outcome. What the funding wanted us to do was have a look at the provision of culturally safe dental care, because there was a recognition that there was a lot of barriers for folks going to the dentist because of the treatment that they were receiving. So this is a project that goes to that. A lot of text on this one, but basically what we aimed to do was to provide safe, comprehensive dental care, and then to really see if there was going to be an improvement in general health, oral health outcomes, particularly around the oral microbiome. So again, we did a lot of work in participants' home or at community centres or sometimes in a clinic. We did a lot of work with the reference group because some of the questions that we ask in questionnaires are just the standard generic questions of OHIP, for example, and they are often quite negatively worded. And I think that what we're hoping to do, this is a movement in Australia now, is to use a positive framework. So a lot of the questions were then reframed so that there was just a bit more a strengths-based approach to it. So we do dental examinations. We were really interested in listening to participants' experience of dental care in the past. We collected plaque and saliva and calculus too. We did lots of point of care testing just to test for early stage, for HbA1c, which is type 2 diabetes, CRP, which is a measure for cardiovascular disease, and the ACR, which is for kidney disease. The great benefit of point of care testing is that you can provide the results immediately back to the participant. But a lot of the work was actually spent in looking for dental care. So with some of our participants, they were eligible for care through the public sector. So we're able to facilitate those appointments. And we received a lot of pushback from receptionists. And so it gave us a real taste of just how hard it is if you English is often a second language for many of our participants, and there's a reluctance to talk on the phone to who are often, white receptionists who don't sometimes have a lot of time for Aboriginal patients. So we would then provide that support, and we'd take we'd always organise the transport as well. Okay, so in the end, we saw over 400 participants for the study, and we had lots of samples collected, so over 1,300 for that. We were able to refer 200 participants to the private sector and about 100 to the public sector, and 80% did manage to receive comprehensive dental care. We're still working on the remaining 20%. Some just still didn't want to go, but we're still hoping. I think the big success story, or one of the big success stories here, is that we did manage to have 3 kidney transplant, clearance for kidney transplant as a product result of this study. So we're doing some follow-up work with that now. I need to move. Yeah. Why is that not going? Sorry, I can't seem to. Next. All right. Okay, so again, some images around that. Same sort of deal. We travel to a lot of remote communities. We do some of the clinical examinations in a clinic, but otherwise we do them in participants' homes. Right. This is one of my favourite studies. This is really looking at some of the systemic racism that occurs in our dental schools, in our dental provision frameworks, and some of the broader groups who we have to work with. So, for example, APRA is the regulatory body that we all need to register with to do any sort of health provision. So I'm just going to read you out this quote because it basically is the nexus for why we were hoping to do it. So I've noticed when you go to the dentist and all that, especially being a Black woman, they don't talk to you. They talk to the secretary about you. And then you've got to remind them, hello, I'm sitting right here. I just want to be treated as a person. And I want my children to be treated for who they are, not by the colour of their skin. So these are the kind of stories we get all of the time. They feel invisible. They feel disrespected. And they just want to be treated like everyone else. So in Australia, there has been, following the movements in the United States, there's been a lot of awareness now of the inherent racism, which is in covert, overt, in personal views and actions from society, but also in institutions and in policies. So if we just take a bit of a snapshot from what we put in the grant application, so we've got 9 dental schools in Australia, we've got a number of peak bodies, but none of them are led by Aboriginal Torres Strait Islander persons, and some of those other metrics were presented by Cathryn before. So again, we've got a few co-designing, yarning, evaluation dissemination frameworks that we use. We tend to use these across all of our projects, but really what we want to do is to apply the evidence and best practice for dental health systems that foster the provision of anti-racist dental care. So this is a big body of work. We're working at a national level with that. And again, lots of project governance. There's lots of co-design. We're working with Indigenous folks as well as all the sort of the dental school leaderships and that sort of thing as well. Okay. But I think what I really want to emphasize here too is that a lot of the work that we have done really requires time. The partnerships cannot be rushed. The objectives that we have as researchers are often not in alignment with what the objectives are of different communities, their ACHOs and that sort of thing. So whilst dental is a big issue, and many ACHOs will see that dental is having a big impact, especially on the children's health and well-being, the actual difficulties in working with communities can be because there's so many other conflicting priorities. There's a lot of death in communities. There's a lot of conflict with different tribal groups. There's often poverty fueled by a lot of behaviours that are fueled by substance abuse. And there's history, there's colonial processes that have led to mistrust of many of the politicians and the policymakers and the leaders of the country, if you like. So it's a slow burn, I think. But I think it's very exciting because we are seeing more and more representation at a parliamentary level. So this is a photo taken at the beginning of the year of Indigenous persons who have members of Parliament. And there's a stronger voice. There's way more recognition by the general Australian population of why we need to address racial inequities, and a willingness to learn. All right, that is the end of my presentation. Thank you so much for your time. I would love for you to come and visit us. We would love to see you. You'd be very, very welcome to come and do some field work with us because it is a real privilege working in this space. Thank you.
Well, thank you so much. It's a real privilege to learn from you and hear that presentation. We've got some great questions lined up in the Q&A. So we'll spend, and we've got plenty of time to address them too. So we'll spend some time on that. Kristen will lead the discussion. And then Professor Jamieson, after we get a chance to address your talk, we'll open it up and we'll have all the speakers, any comments or questions for them, and we'll have a bit of a group discussion. So thank you.
Great. Hi, Lisa. There are a few technical questions about sample collection. Maybe I'll just start with those. So a couple of questions. One, what are you checking in the saliva sample? Why don't I just give you a couple with the technical ones. And the other is with the oral HPV project, what assay did you use?
Oh gosh. Yes.
Another was asking, had you considered urinalysis for fluoride? Those are probably the three main technical ones there. So maybe start with those.
No, great questions. In the saliva, we send it off to a specific laboratory in Melbourne, and they test for HPV types. So I have no idea what the assay is. I could probably find it out. You know, I'm big picture. I kind of sit back and think of ideas to write the grants and stuff. When it comes down to the nitty-gritty, I really have no idea. But I can, if that person wants to email me, I can certainly find out what assay that we're using. I know that they had to tinker with it. And urinalysis for fluoride, that's a really good idea. Someone else suggested that we can analyse fluoride using hair samples as well, but many Indigenous groups in Australia, their hair is very sacred to them, and so taking hair is it's a tricky sort of thing. Happy to give saliva samples, but not so keen to give hair samples. So that's interesting. But thank you for that feedback. I'll take that back to the team. All right, next questions, Kristen.
Great. Okay, this one's more about translation of research findings, wanting to hear if you could expand more on specific impacts, how they were achieved, because this is a significant challenge for this type of research.
Sure is. Yes, I completely agree. I think where we're getting the most momentum at the moment is with silver diamine fluoride. So I think it's often easier to sell the products of research when you work with children, because I think that many, certainly in the Aboriginal space in Australia, because there's a great love for children in Aboriginal communities. And I think that when children are struggling with dental abscesses and they can't eat and they're struggling to learn and they're not sleeping at night, there's an emotive response from communities. So the silver diamine fluoride has just, it's been I don't want to sort of toot my own horn here, but it's just been unresoundingly successful. The team have just been so welcomed. The communities have all come around, and they are writing letters to their politicians, their local members of parliament, around we need silver diamine fluoride because it can be applied by non-dental staff. That's going to be the next barrier for us, is getting it actually approved to be painted on by Aboriginal health workers, for example. So what I love with silver diamine fluoride is that it addresses active decay. So whereas fluoride can be used to prevent decay, silver diamine fluoride just stops it in its tracks, unless it's wholly involved, and then that's a different pathway. So the translation piece for silver diamine fluoride, I think, is going to be the first one that we really get some traction with. We have had some success with oral HPV because we've recognised the higher levels of HPV types 13 and 32. But it's not sexy. You know, no one's heard of the kind of conditions. No one's heard of Hex disease, right? Probably if you've been to dental school, you might recall some slide that you looked at when you're in the 4th year. So that's a bit of a harder sell. Oral pharyngeal cancer, though, is certainly increasing in incidence. And so we've got a little bit of a translational piece around that, again, providing screening in Aboriginal communities. And I think the policy translation around the racism stuff, so similar to what Cathryn has been doing around culturally competent dental workforce training through the dental schools, that's going to be a big ticket item, but there's so much resistance. It's embarrassing, actually. I might leave it for that for now, Kristen, if there's some more questions.
Sure. And related to resistance, there's a political related question related to Australia. There was, I guess, a referendum on Indigenous voice to Parliament last year that was unsuccessful, with 60% of adult Australians saying no. Has there been any impact on the research that your team is currently undertaking from this?
Yes, that is a very good question. Yeah, so we were really caught up in that referendum. I mean, many of us were devastated by the outcome, but many of our Indigenous colleagues that we work with and the ACHOs didn't support it. And that's hard, because I think that as much as we try to walk in the shoes of what it must be like living in an Aboriginal community, we don't. And so we never, ever really get it. I think that it became very political. I think it was very easy for the naysayers to get momentum, and the social media hype that then built up to this tsunami of resistance. It was just way bigger than what we had anticipated. But I think it led to an opening of a conversation. I think that eventually there hopefully will be a referendum, and there'll be a lot more neutrality, if you like, in terms of the discussions that are moving forward, because it just became so inflamed. It became very emotional, and it was actually quite hard for us to work in community, because we couldn't talk about it in the end. It would just lead to disagreements, and that's never a good thing when you're trying to do research collaborations. Great question, though.
Thank you. Let's see, this one is more of a research outcome question. Has anyone considered the percent of the population free of toothaches per annum and per life? Isn't this a universal desire of individuals of any age, yet we don't collect this data or have it as a goal?
Great analogy. Yeah, and I think, yeah, that's really, really good, because I think as clinicians, we're often focused down on the dental disease, right? We look at the caries, or we look at the periodontal disease, but we're not looking at the subjective experience of each participant. So at a societal level, the riddance of toothache is a really important outcome. One of the things I really like with the OHIP measure, so the oral health impact profile, is that they look at, well, it sort of explores pain and appearance and function. And those three outcomes, so Gary Slade developed OHIP, and he did a whole bunch of focus groups with a bunch of Adelaideans, and those were the three factors that came through. It was the pain, the appearance, and the function. And so there is a section of and the OHIP around the pain. But that's not a bad idea in terms of, I'm just always thinking of funding hooks, getting the hooks in so we can get more funding. But a society that's free of toothache is a really good angle. Thank you.
Okay, let's see. Risk factor question. Which risk factors were associated with HPV infection in this population? HIV positive, for example.
Yes. It was so hit and miss because it changed over time, because we've, we had baseline 12-month, 24-month, 48-month follow-ups. Living in a remote community tended to be a risk factor, but there could be links with tobacco, smoking, alcohol, that sort of thing. There was a small link with same-sex relationships. There was a small link with oral sex behaviors. But really, we want to look at patterns over time, because we want to be able to see, because HPV, the infections tend to wash out. So what we want to look at is the persistence of the HPV infections over time. So those who had an HPV infection at baseline 12 months, 24 months, so that's what we're really focusing on, because that virus hasn't been cleared yet. And I think we can probably get a better sense of what the risk factors were when we take that longitudinal approach.
Great, thanks. I think that covers the questions that were specific to you. And I'm thinking I might go back to a couple of questions from our previous speakers who didn't have the chance, and then maybe we can come back to some questions for all of you here. One was for Max, from another student. What advice would you have for someone who wants to provide critical dental care to communities currently impacted by heavy warfare, like the Indigenous Palestinians in Gaza?
Hello?
We can hear you.
Oh, okay. Oh yeah, that's a great question. I think that's something a little bit out of my element, but I think if you really want to go out there to use known networks within your space and reach out and see, get a lay of the land and try to assess what's feasible for yourself and increase expanding your network and reach out to those who may be a friend of a friend or a colleague, and make an attempt if that's so desired, and be safe.
Thank you. We have another question for Dr. Lawrence, wondering if you can say a bit more about the Indigenous Data Ownership Policy Framework that is trademarked. Was that the OCAP? And
Yes,
do they
the OCAP,
share the policy framework with other Indigenous communities?
Absolutely, yes. A lot of work went into it, and obviously by the Indigenous community. And I would say that if you type fnigc.ca, you get to the First Nations Information Governance Center website, and then you do OCAP, and then you have a Fundamentals of OCAP training module that all researchers should take because it's applicable globally. And it costs a little bit of money, but it's worth it. And so again, if you type OCAP, Fundamentals of OCAP First Nations, you get to this site, and fnigc.ca. So it addresses data ownership, how researchers should deal with research done in Indigenous communities with data that is owned by the community. Talks about data sharing agreements, talk about all the principles of Indigenous principles of respect, trust building, etc., etc. So it's really a good resource.
Great. And another question for you, related to the SDF intervention. The question was, did you consider offering glass ionomer cement to cover the stain and to prevent, and then also to prevent access to carcinogenic foods and drinks?
Well, we were in crisis. There were 1,000 children on waitlisted for general anesthetic in one of the areas in northwestern Ontario, 1,000. So the SDF takes 1 minute to apply, 1-minute application. If you are going to cover the upper maxillary teeth with SMART technique, that will be 20 minutes or more. So in times of crisis, we did the SDF without the SMART, the GIC. So, but it's certainly something important, of course, the aesthetic component. I think Lisa had having some experience with Riva product that does the iodine on top. In Canada, we use the North American Advantage Arrest, and there is a lot of discussion whether the iodine, potassium iodine, is actually affecting the remineralization of the surface of the tooth. So again, we adopted what Health Canada uses, which is Advantage Arrest. So it would require the GIC on top for aesthetic purposes. But I will leave it to Lisa to discuss the Riva if she wants to pitch in with that comment.
Yeah, thanks, Herenia. Really good point. We will wait and see. I mean, that is the risk with using the potassium iodide to absorb those loose silver ions that cause the staining. It would make sense that there's going to be some impact at a cellular level in terms of the potassium iodine. I guess we can see in our follow-ups if the silver diamine fluoride has been as effective. The issue is that every child has received the potassium iodine on top of that, because we didn't get the approval to have another control arm that just had silver diamine fluoride without the potassium iodide to absorb those loose ions. But I think ultimately there's still going to be less decay than what there was if there was nothing applied. So I think that would be the angle taken in the Australian ACHO space.
Thank you. And then one more for you, Dr. Lawrence. The question was there an association between caries arrest and length of time of SDF application?
Yes and no. There was like almost a complete arrest after 4 to 6 months follow-up. But then if you stretch it to 1 year or even 2, you got 60%, around 60, 65. So again, the 12-month follow-up and the 20-month follow-up were basically the same rate of arrest. So the question is 60%, 65% enough? Okay.
Okay, thank you. I think that covered most of our audience questions. I could pose one more if there's time, Ben. Okay. I just wanted to ask, I just have been so impressed all the incredible work that you all have been engaged in and learning so much about decolonized research methodologies and concepts and the work that's happening, the political environment, the practical application, Max out there in the field. There's just so much going on, so much hard work, but so many challenges. I'm just wondering whether you might comment on biggest challenge and maybe a really positive success for us in your work. And
I think Lisa should start. Yeah.
Okay, great.
Yeah, I'm happy to start. And I always get myself into big trouble for saying things like this. Our biggest challenge with our research projects, and I think a little bit more in the general sphere in Australia, has been the dental practitioners. So for the culturally safe dental care project, where we provide the dental care to our participants, we have had so much reluctance from dental professionals to treat our staff. I won't share some of the comments because that's what I get in trouble for, but there's incredible resistance to treating Aboriginal persons in Australia. We are paying for this care. We're booking the appointments. We're transporting the participant. We're waiting for the end of the appointment, and we're taking the participant back home. But the language which is used and the disrespect, which is often very, very obvious, the sort of snide comments, that is our biggest challenge. I've kind of given up, to be honest, on any health professional who's over the age of 50, dental health professional. But I think there's probably a lot of hope for the newer kids that are moving through the dental schools, I hope. But that is certainly our biggest challenge. And positive success, I think, has been witnessing this empowerment, this kind of rage of many Indigenous Australians that they deserve better, and they have rights and they have a voice and they are going to get there. That has been so rewarding to see, and we support them every step of the way because it is their fight in a way, as much as we want to be able to, as I said before, walk in their shoes. And they do need that scaffolding of many, many non-Indigenous Australians to be with them, to be able to articulate their concerns and to work with Indigenous groups from around the world to do that as well. I think that is a success, which is hopefully ongoing. Thank you.
Fantastic.
Am I next or Cathryn is next?
Go for it. Go ahead.
Well, the greatest challenge has been the social and commercial determinants of health. So when we do all the work we do, and then you visit the community, there is one, market or store that sells products that are just full in sugar and the diet being so terrible, and then we are trying to work uphill. It's an uphill battle, and that is definitely the greatest challenge. And in Canada now, we have cannabis becoming legal. We have lots of things that are unhealthy or potentially unhealthy coming up. So yeah, that's the greatest challenge. And the rewards, it's very much, I echo what Lisa had just said, is really to see over my 25-year career, the empowerment, that we have more Indigenous scholars, we have Indigenous students getting into dental school and wanting to go back to their community to make a difference, like Max. And yeah, that is the rewards, and how things are changing, like Truth and Reconciliation in Canada. We have Truth and Reconciliation. We have guidelines for publication of research with Indigenous peoples. We have the OCAP. So a lot of good stuff is happening in Canada. Thank you.
Max, do you want to go next?
Yeah, sure. I would say the greatest challenge, and from my perspective, is I would say sustainability and innovation. And what I mean by that is, for my line of work, going out to remote village and doing this is very rewarding, but I can't be the only one doing it. And I think village travel, going to remote communities, or even staying in a very rural area in a lot of Indigenous populations, you stay there long enough, you form relationships, you form a lot of connectedness to the community. And oftentimes, I think there's a little jadedness in the community, whether I'm Native or not, of kind of wanting to form friendships with people, relationships or trust, because they know that either a student loan repayment, they're going to leave within 2 years or 3 years. And even for me, myself, I've only been here for 1 week. And I think it's very rewarding to get high praise that I'm doing a good job and I'm doing as much as I can, working, from 8 a.m. to as late as 10 p.m. And I think that it's because I know my time is limited, and I think all of my colleagues do that, but it's just not sustainable. And I can understand and give validity to the community, to the people, that, yeah, I would trust you to work on my child or myself or my parents, but then you're going to leave. You're not coming back. And I think that's always the disappointing news, is to tell a community member that you form a bond with, or you meet a patient who was unwilling to work with anyone else but you, and now you're going to not come back, either because of logistical reasons, or in my case, it's exhausting, but they understand it. And I think being more vocal about that is a good thing, to kind of dispel that notion of like, maybe I'll come back. I just kind of a little bit more forthcoming about it, that I'm tired, and I think they can understand that. They travel too. And I really love the speakers that were talking about, especially about the idea of appearance and function, because that is a primary thing. I think a lot of Indigenous communities, as remote as they are, by and large, at least in the US, they have access to internet oftentimes, or to a cell phone, and they want what they see on there. They want to be able to smile and not have maybe SDF stain, or they want a denture that doesn't fall out. And I can understand it. It's 2024. Who wouldn't want those things if they can have it in the city? And that brings me to what I think is great, is the innovation of more tribal leadership and tribal health organizations here in the US adopting more current research sooner. When I first graduated, I think there was a little hesitancy to use SDF. Now we're using it almost routinely and regularly as a preventative service. So I like that we're adopting those sooner. And in my presentation towards the end, having some small tribal health organization wanting to implement technology to expand their services, I think that's the beauty of tribal sovereignty in full effect, is the community members taking absolute ownership and not waiting to be told by a federal agency to say, like, hey, this is okay to use. They just said, I'm going to do it because my community needs it. And I like that. I think that's a really hopeful thing.
Fantastic. Thank you, Max. And then I know we're a little bit over, but hopefully Cathryn can chime in here too.
Sure. So look, from my perspective, I think I probably agree with Lisa that changing the culture of dental schools worldwide. I know in Australia there's some positive steps, but it's only in my lifetime that Indigenous people in Australia have even been able to go to school, let alone prepare for university. 2012 was when there was significant university work with mandating Indigenous culture within curricula, and that just takes time to filter through to ensure that dental schools are culturally safe, and so that when eventually our Indigenous wonderful colleagues and students are coming through, that they stay. And then as far as looking at research and beyond, I think it is a matter of time if we build relationships beforehand, having increase support in dental schools for culturally safe environments for Indigenous students. I have no doubt that the positive flow-on effect will be increasing participation in the workforce among Indigenous colleagues, which will then filter through this culturally safe care will flow. But it's time, effort, and it's not immediate. And I think that's something that is really challenging in all dental schools.
Thank you so much. Thank you to all for your candor on those questions. We really, really appreciate it. And I'll turn it back over to Ben.
Well, thank you, everybody. Thank you just for sharing perspectives. Thank you to our audience. We're a little bit over time, so the last things I'll say are take a look to the chat. We have a link if you would be willing to give us an evaluation on today's presentation. Any comments, any suggestions for themes or speakers in future years, we'd love to hear them. There's also a link if you'd like to get continuing dental education units. And look forward to seeing you here next year. Thank you, everyone.